Okay, so we're gonna review NG tube insertion, gastric tubes, TPN, giving medication via tubes, and just all things gastric tube related. So first, when I come into a patient's room, when I have an order for any gastric tube, I need to assess my patient first. I'm gonna review my orders. There are two different types of tubes that we're gonna learn a lot about in class. I'm just gonna briefly discuss them here so that you'll have this information. We have what's called a Dopp-Hoff or a flexi flow tube. This tube is predominantly used for feeding. So you'll see that it's very flexible. It has a stylet, which is a metal, kind of a rod that goes down into it. That's gonna allow, the purpose of the metal stylet is to allow you to advance this into the patient's nasal bridge, down to their esophagus and into their stomach. And then that's picked up on the x-ray. So when we talk about placement and other things, as we'll learn in the course, the stylet is important for x-ray purposes. So this tube is predominantly used for feeding. Another name is Dopp-Hoff or flexi flow. The other tube that we'll learn a lot about is called a Salem sump or decompression tube. That's going to be used for a patient who needs their stomach pumped, if you will. A lot of people know that terminology if they had a friend who needed that done or had a lot of gastric issues. And it looks like this. It's a lot bigger. The tube is a lot more pliable. It's very stiff. It has two ports and a valve. This blue port, if you will, I want you to look at that. That is called the oxygen port. What this does is this allows air or oxygen. I like to say oxygen just because it's blue, and that helps me to remember that I shouldn't be putting anything into this tube. This allows the tube to decompress. So the air flows into the very big, tight stomach, decompresses that stomach, and creates a Salem sump or a siphon, kind of a siphon if it's not connected to suction, and it will siphon that gastric residual out into whatever canister that you have through this port. And this is your connector to your suction. Okay, so this tube again is called Salem sump or decompression tube. We're gonna talk about each. Putting these down, you're gonna do it in the exact same way, okay? Exact same way. I find that it's important thinking about what's the purpose of your tube. So based on your patient's condition, you're gonna know the purpose of your tube. If you're planning to feed a patient, your doctor may just say, place an NG tube. He may not say Salem sump or Dopp-Hoff. You've got to know your patient, understand what the use of that tube is. So if you know your patient needs nutrition, you're going to select this tube. If you know that your patient needs gastric decompression or air removal, or they're planning for surgery and it's not related to nutrition, this is the tube of choice. But keep in mind, your orders are going to tell you that, but sometimes you have to use your brain and think about what you need. Okay, so before I place any tube, one of the important things I need to do is to assess my patient. So I'm gonna, there again, like we've been doing, can you tell me your name and date of birth?
Janine Rochester.
Janine Rochester. When were you born, Janine?
7/20/80.
Okay, great. Well, let's talk about why you need a tube. So I understand that you've been having a lot of stomach pain, you've been bloated, and I'm gonna just tell you this is a not comfortable procedure, but the doctor has ordered for you to have a nasal gastric tube. This tube you've been vomiting all morning is going to basically suck that residual out of your belly, or vomit, if you will, and be connected to a reservoir so that we can collect this drainage. It is not comfortable. I'm probably gonna get a buddy. I will need a buddy to help me to coach Janine in this process, more or less just to hold her hand, to be more of the comfort while I focus in on the skill that I'm about to do. Is that okay with you if we do this, Miss Janine?
Whew, I guess.
I understand. It's gonna be really hard, but listen, I think the best thing about this is that the outcome of this scenario ends up making you feel so much better, but it's just not fun in the process. That's life, isn't it? Generally speaking. Okay, so the first thing I want to do is I want to assess her nair. I want to make sure to see if there's any obstruction, drainage, boogies if there are boogies in there. We've got to look for those things. So both of her nairs look very patent. They look great. There's no issue there. I might even ask her if she had a nair that gave her trouble. I'm also going to look for septal deviation. Does her septum look in line? It does. There's no deviation there. So the next, after I've assessed her nasal patency, I'm going to measure, and I'm going to start by measuring from behind the ear to the nose. And then I'm gonna measure down here. Now, I know the textbook says to the xiphoid process, but let's just be clear. Is anyone's stomach right here in the xiphoid process? The literature says, depending on the size of the patient, that you could go beyond 1 inch to 5 inches. Let's think about a very large man with a lot of abdominal girth. Would you think you would need to do 1 inch or about 4 or 5? So you've got to use that nursing judgment to determine. Janine's pretty thin, but if I feel for her xiphoid process, this is right here, and I figure her stomach is probably about here. So I'm gonna add that on to her measurement here. So that looks to be about 75 on my tube, okay? So at 75, I can either place a piece of tape, get a magic marker, permanent marker, mark on there, but I know it's 75. A lot of the DOPHOFs do not have graduated marks. This one actually does, but you see these little plus signs here. You would probably need to mark that if it did not give you a number grade. So those are some things to think about. Here again, facilities have different types of products, so you just want to make sure you're doing the best thing with what you have to work with. All right, so we've measured, we know it's going to be 75. So I need to assess, can my patient swallow? Well, Janine's already talked to me. She's telling me her name and date of birth, her nasal patency, and I know that her issue with her condition is not related to a swallowing problem. She's got a stomach problem. There's something abdominally going on with her, so she's capable of swallowing. So I want to assess that. So I might could get an ice chip. Yes, she may be ordered to be NPO. NPO because we don't want to add food or nutrition to this problem, but we can get her to swallow a little piece of ice just to make sure that she's going to be able to pass this tube properly. So I may get my buddy to hold Janine's hand, but also ask her to maybe do a little sip of ice or a little piece of water.
Ooh, that tastes good.
I know your mouth's dry, isn't it? Okay, so she swallowed that well. So one of the best tips and tricks, this is not in your textbook, is to have a buddy feed her a piece of ice, and as you advance this tube, you're gonna have her kind of swallow on that ice the water, not the ice chip itself, but the water, so that as she's swallowing onto that water, she's going to easily advance this tube, because I'll be honest, this is not a graceful procedure. All right, Janine, are you ready? Here's what we're gonna do. I'm gonna talk you through this. So first thing we're gonna do is we're gonna have you place your chin to your chest. So placing the chin to the chest, you're gonna insert the tip of the catheter. You would lubricate this. Most of these do come pre-lubricated. This one is not, but our mannequin doesn't really like lubrication in its nose, so we'll just go with that. All right, we're gonna chin to chest, and we're visualizing that we are inserting the tip here into the patient. Okay, now, once you feel like I've not elicited her gag reflex yet, so I've gone in about 4 to 5 inches. Now I'm gonna ask her to tip her head back. And the reason for this is because I'm gonna ask her to open her mouth so that I can visualize the tip of my NG tube in the back of her throat. She's not gagging, she's not coughing at this point, but we're about to. I'm not tell her that just yet. Okay, Janine, here's where we gotta work together. I know, so I'm gonna get a little piece of ice, place a little piece of ice in your mouth. Now, Janine, when I tell you to swallow, I want you to suck on that piece of ice and swallow, because this is gonna feel uncomfortable. I have to get past the glottis and the gag reflex to be able to get this tube down to my goal of 75. That's a long way, right? Okay, so her head's tilted back. Now, Janine, I want you to swallow. Swallow. And she's probably gagging, coughing, maybe vomiting as well. So really, about keeping me at this point, you might want to wear goggles in doing this, or a face shield. Because am I really up in her business here? I am. So I'm going to advance and advance. She's doing great. We're going to coach her. We're going to tell her how great she's doing. She might be crying. She might be uncomfortable. It's a very difficult procedure. Okay, so I get all the way to 75, and I'm supposed to be able to get this down. Let me see if I can try it in here. Okay. All right, so we got to 75. We'll just say we did, because it didn't really go in there too good. So we're at 75. So now, if I'm in her stomach, what do you think is probably coming back into this tube? Well, I didn't show you my trick. But one thing that I like to do in putting this tube in is to automatically connect my syringe to the tube, because as soon as it gets down, instead of having this open for gastric residual to spray all over you and everybody else, if you have the syringe here, you can automatically fill this up with your gastric secretions in there. So I know I'm in proper placement. One thing we'll talk a lot about in class is about the difference between whether or not an x-ray is needed, but we know that this tube is not to place anything inside it. We are trying to take things out of our patient, so an x-ray is not necessarily required. If we ever were to use this thing to administer any medications, fluids, or anything else, it would need an x-ray. But for now, we're not. So we know that we're in proper place. We're going to secure this to her nose. A lot of places have what they call a nasogastric band or something on the nose. I like to always wipe my patient's nose, because a lot of times when we've been vomiting, you're kind of sweaty, your nose might be sweaty, so you might want to clean the nose. Place your tape. I call it the mom gene. You're going to cut your tape to look like little pants by pulling the edge on. I don't have any because I'm not super prepared, but I'm going to attach the tape to my patient's nose and then wrap it around to secure the nasal bridge here. And we'll talk about this more in our course class, but just to show you here. Okay, so it's intact. So now I want to check for placement. So what I'm gonna do is I'm gonna have on my stethoscope, which I don't have, but I would have it on. But put on my stethoscope. I already see that my patient has gastric residual here, so we'll pretend this is green. And I'm gonna show you again, I'm gonna show you the peg, and I think she has some stuff in there for us to see.